So good evening, everyone. This is Dr. Rakesh Sahai. I'm a professor of endocrinology at Usmania Medical College in Hyderabad. So we are indeed privileged to have this series of endotext webinars where we have in this first one in this series, we are very privileged to have with us Professor Kenneth Fingold, who's the editor of Endotext, which is a very well-known resource in endocrinology, online textbook and endocrinology, which is in existence for several decades now. And I have great pleasure in introducing Kenneth Fingold, who is the emeritus professor of medicine at the in the endocrine section at the University of California, uh, San Francisco. For many years, he was chief of the endocrine clinic at San Francisco VA. Could we have his slide on the screen?
Hello, everyone.
Yeah, he's been a member of the American Society of Clinical Investigation, American Diabetes Association, and the Endocrine Society. He's associate editor of the Journal of Lipid Research. He has served on the NIH study sections at the VA Merit Review Board of Endocrinology, and his clinical interests have been in the field of lipids and diabetes. And we are indeed privileged to have him here with us. And we also have with us Dr. Rupa Mehta, who's from Mexico, and she is she's in the metabolic disease research unit at the Department of Endocrinology in the National Institute of Medical Sciences and Nutrition, Salvador, Mexico City. She is an associate professor in both pre and postgraduate endocrinology programs. She has been a principal investigator for several phase 3 clinical trials. Research interests are particularly in the field of diabetes, type 2 diabetes, metabolic syndrome, and lipid metabolism. She has presented at the American ADA congresses, the European, the ESD congresses, and also at the American Association of Clinical Endocrinology, that is the ACE meetings, and has presented her research at several national and international setting meetings. She is associate editor for diabetes medicine and an advisory board member and a reviewer for diabetes therapy. She has received several prestigious awards, amongst that the Alfred Riven Research Award and the Young Investigators Award from the American Association of Clinical Endocrinologists. Endocrinologists are the major ones. And she has co-edited a book on book for patients, that is Living with Diabetes, a Practical Manual. So indeed, we are privileged to have her with us today. And we have two young endocrinologists, one from India, Dr. Aishwarya, who's working at the Max Super Specialty Hospital. She has qualified, has done a DM in endocrinology from the prestigious All India Institute of Medical Sciences, and she has won several awards, amongst which she has won the best gold medal for her best thesis in MD medicine from JIPMER in Pondicherry, and she has also received the Pratibha Merit Scholarship by the government of Andhra Pradesh. And she has several other interests apart from medicine. She has also been the literary and debating secretary at the JIPMER Institute when she did her undergraduation at JIPMER. And also with us, we have Dr. Edutu Williams, who's from Nigeria. She's a senior registrar in endocrinology, diabetes, and metabolism, subspecialty of internal medicine at the Lagos State University Teaching Hospital in Lagos in Nigeria. And she has done her undergraduate training at the university in Nigeria. Again, in Nigeria, she's an associated fellow of the National Postgraduate Medical College of Nigeria and a member of the West African College of Physicians. She's a member of Endocrine and Metabolism Society of Nigeria. So she's also going to be here with us and present a interesting case today. And we will now move on to the presentations. And we have with us, we have two interesting cases being presented, and we have the discussion along with that. And so I would request Dr. Aishwarya to start with her presentation first.
Thank you so much, Dr. Sahai. It's really an honor to be here, and I thank the organizers for a chance to present in this webinar. So today I'll be presenting a case. Just share my slides. Sir, are my slides visible?
Yeah, we can see your slides. We can hear you also. So you can go ahead.
So the first case, this was an interesting case that we saw. It was a young patient. She's a 19-year-old girl who had no previous history of any cardiac complications. She had no previous history of any cardiac symptoms like palpitations, no history of angina, no history of dyspnea before this, no history of any syncope. She also didn't have any other comorbidities like diabetes, hypertension, no history of any thyroid illnesses. And she presented to our emergency with a history of severe anginal chest pain and dyspnea for 1 hour prior to presentation. So she didn't recall any history of fever. There was no history of any medication intake, no history of any recreational drug intake. And this was a young girl who was unmarried. She didn't smoke, and she had regular menstrual cycles prior to presenting in our ER. So she was a young girl who was a student, but she did recall on probing his family history. She did recall that she had lost her mother suddenly. When the mother was 35 years of age, she had lost her mother, and also she recalled that the mother had lost her brother at the age of 27 years of age. So she didn't really know the details of the medical history of the mother, of what actually led to the demise of the mother, but she did recall that she lost her mother very early on in life. So this was the history that we had of the patient. And on physical examination, she was a thin-built girl. She was moderately nourished. She had a body weight of 54 kgs and a height of 146 centimeters, which gave a BMI of 22.1 kg per meter square. And the significant thing that we found on her examination, which we noticed when she was lying on the bed in the ER, was multiple soft, painless subcutaneous swellings over her hands, over her knuckles. She had these over her Achilles tendon, and they looked like xanthomas. So when we probed further, she recalled that that the mother did have similar skin lesions, and that she had a younger brother who wasn't there in the ER at that time. So he also was 15 years old, and he had similar swellings all over his extremities as well. So an eye examination, so since we saw this, so we looked at the eye, and the eye examination revealed a corneal arcus. Her vitals, she had a pulse rate of 120 per minute. She was tachycardic, but the pulse rate was regular. And she had a respiratory rate of 32 per minute. She was tachypneic. She had a BP which was 118 by 60 millimeters of mercury on the lying down position in the right upper limb. She had a saturation which was low, 90%, but it improved to 98% by supplemental oxygen by a mask at 4 liters per minute. So these were the findings of Arcus and of the tendon xanthomas at one side. And the systemic examination, a JVP that was elevated, but she didn't have any precordial bulge, and the apex was localized at the left fifth intercostal space medial to the mid-clavicular line. S1 and S2 were heard. There were no murmurs, but we did hear an S3 gallop. So the respiratory rate, she was tachypneic. She had symmetrical chest movements, but we did find bilateral basilar crepitations. Now her abdomen was soft. She had a hepatomegaly of 2 centimeters below those. It was a bilaterally equal and reacting, and she had no focal deficits. So we did certain investigations in the emergency room. So we did, since she complained of anginal chest pain, we did an ECG, which showed a sinus rhythm with a 2 millimeter ST segment elevation in the V2 to V6 leads, and also in the lateral leads, lead 1 and lead AVL. And we did an echo, which showed a hypokinetic anterior wall of the heart. The LV ejection fraction was also low at 30%. She had normal walls, and there was no effusion. And we got a chest X-ray done because she did have tachypnea, and there were bilateral basilar crepitations. And it showed a typical batwing airspace shadowing and a batwing appearance suggestive of pulmonary edema. So we got a cardiac enzyme done since she had the ST elevation, and it was clearly elevated at 13.2 nanogram per ml. And so we got her other labs done. She had a normal renal and liver function test, and she had a normal hemogram. So we also did a random blood glucose, which which was around 86 milligram per deciliter. And so we got a lipid profile done at admission. This was within 24 hours of the acute event. And this was very interesting because we had a very grossly abnormal lipid profile. So we had a total cholesterol that was 657. We had an LDL, which was 572. And she had an HDL, which was 61, and a triglyceride of 122. So we also followed this up with an HbA1c, which showed a value of 5.6%. Her thyroid profile was normal. We also did a urine exam because since the lipid profile was so abnormal, which was normal, we were looking for proteinuria, which was not there. So we did a biopsy. This happened a little later. I'm just presenting it to complete the flow of investigations. We did this a little later on after stabilization. So the biopsy of one of the swellings in her wrist showed lipid-laden foam cells, and it showed multiple cholesterol clefts, and it was suggestive of a xanthoma. So when we looked into the history, I'll just present this first before I go to the diagnosis. So this was a history that we could get from the patient. So she was a 19-year-old girl who was recently married. And so she had a younger brother who did have similar skin lesions. He had not been evaluated before this. And she did give history of losing her mother and her maternal uncle at a very young age. And the reason was not known. She did recall that the mother had swelling similar to hers over her extremities. So we followed this up with the brother's lipid profile, and that was also grossly abnormal. So we had a total cholesterol which was 630. We had an LDL which was 554. We had an HDL which was 50, and a triglyceride which was normal at 130. So we also followed this up with an ECG which was normal. We did renal and liver function tests which were normal, and his blood glucose parameters were also normal. And his TFT, we just did a TSH for cost constraints, and that was normal. So with this, we could arrive at, so we use the Simon-Broom diagnostic criteria for familial hypercholesterolemia. So the total cholesterol was higher than 290 milligram per deciliter. There were tendon xanthomas both in the patient and a first degree relative. We didn't have a genetic analysis report, but we did have a family history of myocardial infarction in a first degree relative. The mother died at the age of less than 60 years. And also there was the family history of another first degree relative with a high cholesterol level. So we could make a diagnosis of a definite familial hypercholesterolemia. So I'll come back to these slides. So we made a final diagnosis of an acute anterolateral myocardial infarction. She also had acute pulmonary edema at presentation. She had coronary artery disease, and she had a definite familial hypercholesterolemia. So with this diagnosis, so the acute management, she was admitted under the cardiology team in the hospital, and she underwent a primary PCI, and she was managed for the pulmonary edema. And for the dyslipidemia, we were consulted, and the initial measures that we did, like we need to do for all patients, we gave the patient strict dietary measures, and we put her on a high dose statin of atorvastatin around 80 milligram per day. And we also gave her ezetimibe 10 milligram per day. And 8 weeks after treatment with these, her LDL had come down by 50% to 302, which was still very high. So we had to start her on evolocumab, which was very expensive, but we had to do that. So it was 420 milligrams sub-Q once a month. And at 8 weeks, the LDL cholesterol levels were 110 milligram per deciliter. So this is how we managed this patient. These are the things that we would like to discuss in the case. Dr. Sahai,
I would like to actually get in Dr. Ken to tell us a few points here, what he feels about this patient, and what are the issues that he would like to highlight here in this patient.
I think there's a couple of things that are worthwhile pointing out. The first is when the mother and brother and her brother, the uncle, died, there should have been an investigation of their lipid levels. And if they had high lipid levels, which is very, very likely that they also had FH, it would have allowed early screening of family members. I think that this is a crucial point for all clinicians. Familial hypercholesterolemia, at least in the United States, is a fairly common disorder. In fact, people have often said it's the most common genetic disease that occurs. And the key to this is to pick up people before they have events. So when you see people that have high cholesterol levels, LDL cholesterol levels greater than 190, you have to think of genetic diseases. And it's really imperative to check all the relatives, to do cascade screening. So if the mother was diagnosed with an MI at age 35 and the lipids were high then it would have been imperative to check the daughter, the son, brothers, sisters. In other words, you start searching out, looking for this disease early because we have treatments that can lower the LDL levels. And therefore, we can prevent the presentation that we're seeing here, where a 19-year-old comes in with, well, what I would call a catastrophic event, a myocardial infarction leading to congestive heart failure. Conceivably, this could have been prevented. The one piece of data that's missing here, well, there's a couple pieces of data that's missing here, is I'm curious about the father and what were his lipid levels. In other words, does this represent a homozygous? If it does, then the treatments are different. I actually don't think this is a homozygous for a couple of reasons. One is we don't have any information on the father, and I would presume that if the father had high lipid levels, that would have been checked. The second is the good response to the lipid-lowering agents. People with homozygote FH usually do not have a dramatic response to drugs that affect the LDL receptor number to lower lipid levels. And this fact is that this patient had a wonderful response. And that leads one to think that this is a heterozygote. Now, why does this heterozygote have such high LDL cholesterol levels? Well, it turns out that there's other genes that can affect the LDL cholesterol levels. And this may be an unfortunate family where they have FH and on top of that, other genes that influence cholesterol levels. Because remember, for all of us, there's this entity called polygenetic hypercholesterolemia. And they may have a combination of an FH gene and polygenetic gene disorder as well, superimposed, giving them much higher LDL levels than we're used to seeing in a heterozygote. And that makes this case very interesting. What would be very interesting to do, but I don't know that if it's available in India. In the United States, we would definitely do genetic testing on a patient like this to specifically find out what genetic disorders she has. That would be very, very important. And I think I'll stop here and turn it over to Dr. Mehta and see what her comments are regarding this case.
I think you've covered a lot of what we would discuss in this case. And I agree, I think the genetic testing is very important in this case. But remember, we know that the main genes affected are the LDL receptor, ApoB, and maybe PCSK9. But in a lot of the cases, we may not find a mutation in the LDL receptor, which is most common. So they're estimating that about 60% of cases we may find a mutation, but in 40% we may not. And in fact, I saw a similar case in our lipid clinic, very similar. And when we did the genetic testing, looking for mutations in the LDL receptor, it came back negative. So as Dr. Ken is saying, this may well be an FH with a polygenic component. And the other point here, I think that he made very, very clearly, the idea is to prevent the outcomes or the cardiac outcomes in this disorder. So obviously things were not detected on time, but now we need to concentrate on the other family members. You've given us a small family tree, but in India, the families are very big, just like in Mexico, and just seeing how many other family members are affected and start with preventive measures. But Dr. Ken, that was an excellent analysis of this case.
Dr. Rupa, thank you. Do you think that we should be screening more than just looking for presentations like this? Do you think that we should be picking up heterozygous hypercholesterolemias because they are the more likely, more common ones that we may be facing?
This is exactly what Dr. Ken mentioned. In my opinion, this is the commonest genetic disorder, and it's the heterozygous form of the disease that has a prevalence of between 1 in 250, 1 in 300 in the population. So these are much more difficult to pick up. you're not going to find LDL levels in 500 or 600. They may have an LDL of around 220, 230, but the idea is to suspect the disease in the first place. And unfortunately, there isn't enough awareness of this disease, not only in patients, but also in the medical community. So what we do is obviously when we come across an LDL that is elevated, family history is essential. And then secondly, we would, because sometimes we may not find tendon xanthomas. In fact, in a lot of our cases, there are no tendon xanthomas. And so then we need to do then the typical cascade screening and look at the profile of other family members. And if genetic analysis is possible, then that can be a next step. But I think the heterozygous cases are the most difficult to identify, and we do really need to be looking for them actively.
Yeah, sure.
The other aspect, Dr. Rakesh, is establishing a registry, a national registry, because then you can get real prevalence estimates, and then seeing how your population is, you can then put in preventive strategies in the public health arena. So that is also an essential step. And in fact, there was a consensus statement that came out a few years ago that looked into the areas we need to tackle in FH. So obviously research, diagnosis, screening, but establishing registries was another very important step.
So you were just telling us about, how you would pick up these patients. So what are the pointers that you look at? Because they don't have the typical tendon xanthomas and their LDL levels may not be very high. So what are the practical points
So
that...
this is one of the big challenges in FH. Even the diagnostic criteria, unless you have a very typical case, the diagnostic criteria may come back as probable or even possible. So I find that the actual family history and also the actual, doing the family tree gives you a lot of information. You may find that there is a family history of premature cardiovascular disease. Sometimes you won't. Some of the polygenic cases tend to be milder, but you need to suspect in order to look for these cases. Dr. Ken, how do you screen for the heterozygous cases?
Well, let me back up just a touch. One of the recommendations that many pediatric lipidologist experts have been making is to obtain lipid levels at around the age of 9 and 10 on all children. Yeah. Because as you said, the clinical manifestations are often not present. But obviously, if one obtains lipid levels, one can pull out these individuals who have high LDL cholesterol levels that you may not have recognized. And so that's a recommendation that's being made by many experts. And I think it's with a disease that occurs in a population of 1 in 250, that's probably a very good idea in that you can find these people at a young age and begin appropriate treatment at a young age to prevent the sequelae that are occurring. Because I'm not sure that clinically, as you pointed out, the clinical manifestations of this disease are basically silent, particularly at a young age. Then most of these patients are not going to have clinical manifestation. Family histories, at least in the United States, and I don't know if this is true in other parts of the world, can often be very questionable. We don't often have exact identifications of the parents and what's been going on and that sort of thing. And therefore, you can't always rely on family history in the United States. So this screening, I think, is a great idea. And you can screen with cholesterol levels. Once you have a patient with FH and you know the genetics, then you can screen for the actual genetic disorder, because there are people with FH that actually have LDL cholesterol levels less than 190. And so you will miss those if you just screen with cholesterol levels. But I think for the general population, screening with cholesterol levels is the way to go. And once you identify a genetic disorder, then screening for the genetic disorder is the next approach.
In India, we don't have in terms of the prevalence of FH. But assuming that, we also may be having a similar sort of prevalence rate, because Dr. Rupa is mentioning that in Mexico also they have a pretty high prevalence rate. So assuming that we also have a similar prevalence rate, when do you suggest starting the screening? At what age do you think we should screen individuals for their cholesterol levels? Dr. Rupa or Dr. Ken, whoever takes it. Yeah.
I think Ken mentioned it, that after about 8 years of age, but you can do lipid levels after the age of 3 years in a child. But generally, I would suggest after 8, because that's also what the guidelines recommend for considering statin treatment in these kinds of patients. So it makes sense to really screen all children at least at 8 years of age to try and identify. And as he mentioned, universal screening has been a recommendation by many leading experts in this field in children.
For those of you who want to read more about this, there's in Endotext, there's a whole section on pediatric lipidology. And in there, they discuss in great detail the screening procedures to use in young children. I'm not a pediatrician, I'm an adult endocrinologist, but the pediatricians and general and family practitioners should be aware of this, because I think we would pick up a lot of disease early and prevent a lot of severe problems. So for instance, if this woman had been screened at age 8 or 9, they would have found the very high lipid levels and begun the therapy that they've now begun. And what they would have saved her is the loss of a lot of myocardium. So it would have been much better to have done this early than to do this now. So they could have been a decade ahead of time. Instead of 19, they could have begun treatment at 9 and perhaps prevented the catastrophe that we saw.
Yeah, one important question: what would be the target of the LDL at that age? I mean, if you were assuming that this girl was picked up at, say, 8 or 10 years of age, and we then see that she has a very high LDL and she needs statin therapy, what should be the target of treatment there?
Well, you're going to get a lot of opinions on this, but I would aim to get her down to around 100 if possible. Now, it's very, very hard when someone begins with an LDL of 500, and we saw with outstanding treatment in this particular patient. I think everyone should be congratulated. With 3-drug therapy, they got her LDL down to 110. But remember, if you do this early, the genetic studies that we have on polymorphisms indicate that you may not have to get down to 70. If you can get someone down to 100, they may have a myocardial infarction, but it may occur at age 70. You need to think about the LDL cholesterol the way we think of smoking. People have used the term LDL years. So it's the height of the LDL and how long it's been present that determines the severity. And so if we could have gotten her down to 110 like they've succeeded so beautifully in doing at age 9, it's very possible that, yes, she might have a myocardial infarction, but it might occur at age 70 rather than at age 19. And I think that's what we're really aiming for. I think getting it down to a reasonable range would have been very, very good. And how low to go, I would like to see in young people under 100. I think all of us should have LDLs under 100.
Yeah, I totally agree. And I think you mentioned something very important. In these primary dyslipidemias, we're talking about lifetime risk. It's not estimating 10-year risks. It's really thinking about the lifetime exposure to high LDL levels.
A very important question that also needs to be discussed is that this is a young girl who just got married, and she probably wants to conceive. And what would your advice be for that, Dr. Rupa?
So she would need genetic counseling, obviously, and probably check lipid profiles in her future partner. And also discuss, cholesterol goes up in pregnancy and she cannot be on these medications during her pregnancy. So all these things need to be discussed with her so she can make an informed decision. Firstly, if she wants to get pregnant and have a child, and then also the risks associated with the pregnancy.
Ken, would you like to add something to this?
No, I have nothing to add except the drug that certainly has to be stopped is the statin. I don't know that we have enough data with the PCSK monoclonal antibodies. It may be that one can continue that particular drug, even though it's not recommended. I mean, no drug is recommended during pregnancy, but one sometimes has to weigh the off-label use versus because the data isn't there. They never studied these drugs in pregnancy. But I would think that a monoclonal antibody would be unlikely to have great effects during pregnancy.
Since it's, I was just reading about while preparing for this case. So since it's an IgG antibody, it does cross the placenta and it does have a chance of affecting the baby. There is a registry in place right now where they've registering women who are inadvertently exposed to the PCSK9 inhibitors. So probably once we have data from there, we will be able to strongly say what way it would go. Ma'am, what are your views on, do you think these patients would require an LDL apheresis or anything else during pregnancy? Because since we are stopping the medicine as well, and plus the added effects of pregnancy, so what is usually the typical profile of these patients during pregnancy?
So I don't have, we don't have apheresis in Mexico, so I can't give you really an opinion on that. And I'm not sure about its use in pregnancy. I haven't really read enough to tell you. I don't know if Dr. Ken or Dr. Rakesh knows more about the use of that in pregnancy. I don't know if it would be recommended in pregnancy, to tell you the truth. I don't know. Dr. Ken, Dr. Rakesh?
No, I have no information on that. I do know that people have used, because one of the other things that can occur in pregnancy is very, very high triglyceride levels.
Yeah.
And that can be an acute emergency because of pancreatitis. And in those patients, plasmapheresis has been used.
Yeah,
I'm not aware of apheresis, LDL apheresis being used, or lipoprotein apheresis being used during pregnancy. One thing you got to remember is that the high cholesterol levels, it's going to only be for a short term. And the impact on the vessel walls may not be that great if it's only over a 5 or 6 month, 7 month period. And so it's a little bit different than the high triglycerides, which can cause an acute emergency. Here you will have a setback as far as the vessels are concerned. They'll obviously accelerate the atherogenic process. But the atherogenic process, remember, takes years and years and years in most people. Even this patient here who had LDL levels in the 500s, it took 19 years before she presented with an event. So under normal circumstances, if you have a relatively short period of time where someone has a high LDL, that's not ideal, but it's probably not an emergency.
But that situation would be relevant when she did not have AMI, because here she had an MI and she is at risk of a recurrence of the MI.
Here she's got much more problems because we were so late in diagnosing her that she's got, probably a lot of vulnerable plaques still pending in her body. So I certainly wouldn't think that she should become pregnant for quite a bit of time, because we would like to change those plaques that are very vulnerable to being much more stable plaques. And that takes some time. And getting her LDL down for a few years to allow her vessels. I mean, if we did certain kinds of imaging studies, my bet would be that right now her plaques are filled with lipid. They look similar to that xanthoma biopsy that you showed us, and those are unstable and are likely, if the LDLs go back up, to lead to another event. But over time, those can become stabilized. The lipid can be drawn out of those, and you can get a more fibrotic, calcified plaque that's less likely to erode or rupture and cause an acute event.
There's one question in the chat box where Dr. Mohan Chennai wants to know about the role of childhood obesity on this. I mean, do you think if the child was obese, then they have a high risk of having the lipid abnormalities, and particularly in the background of FH? What would be the additional impact of obesity?
Well, I mean, this is, if you have obesity and FH, then It's just the cardiovascular risk will increase. I don't think it will per se influence the presentation of FH, but it's another risk factor that we need to take into account when we manage the patient.
Yeah. I mean, you wouldn't want someone with FH being a smoker, just to make it sort of a simple thing. The more risk factors you add in, the greater the problems you're likely to have. The other thing that one should consider in doing in this patient and all patients with FH is getting an LP little a level, because that also influences risk. Now, currently, there's not much we can do about LP little a because we don't have really very effective drugs. But in the future, in the next 5 or 10 years, depending upon how the studies work, it's very possible we will have drugs that can target LP little a. And many patients with FH have high LP little a levels. And if that's the case, it's very useful to be able to bring that down. So knowing that now may allow one for the future to be able to recognize that that problem exists in this patient, and be able to treat that lipid abnormality as well.
And remember that this is genetically determined. So the level this patient, you really just need to measure it once to get an idea of if LPA is a factor in the risk management in this patient. Because remember, it's genetically determined, so it's not going to vary that much. So as soon as you find a high level, and correct me if I'm wrong, Dr. Ken, over 50 or even considered, a risk factor. But in FH, you probably find a higher, yeah.
I mean, just knowing that, having it on our record would be useful information, because in the future, it's very possible that we'll have techniques to lower the LP little a levels. And if she has a high LP little a, that could be partly an explanation for why she's done so badly.
So Dr. Rupa, could you give us some idea about the prevalence in Mexico? How are you looking at this problem of FH, and how often do you find?
So we have the same problem as you in India. We have a huge country with very poor awareness of the disease among the medical community. So we started a national registry, and we've invited one representative from each state, one doctor who has an interest in FH, to kind of try and help collect cases. And in the registry, we have obviously, the data about each patient. It has to be anonymous. So we have names of the patients, they're just numbers. But we collect the data on age, we collect the data on the screening criteria that the patient fulfilled, family history, and physical examination. And obviously we're relying on the physicians themselves to have correctly made that diagnosis. So right now we have about 700 cases registered. It's not a huge amount because as well, this depends on doctors having time to enter cases into a registry. And the idea is to share this data with other countries so we can do investigation, but also to get some idea of the prevalence and characteristics. A challenge we have, which I'm sure you have in India, is that we can't do genetic testing in every single case. Our center does do some genetic testing, but it depends on funding. So, we can do testing on a few hundred patients, but probably not in the registry. And also what we're finding is that it's generally the cardiologists that probably have more patients than the endocrinologists. But then we're seeing secondary prevention patients there. So the idea is to try and change that around, that we have preventive strategies from an early age, diagnosis that is done in an opportune manner, so that then we can start treatment early. But right now, I suspect in our country, it's a lot of cardiologists, and maybe I need to invite more cardiologists into the registry to capture more cases.
Thank you. So I think we had a very interesting discussion on this. Shall we move on to the next case with Dr. Williams is going to present to us.
It's
I think you're muted. If you can unmute yourself and.
Good afternoon. Good afternoon, everyone, and thank you for this opportunity. Today I'll be discussing a case, a patient with hyperglycemia who was found to have severe hyperlipidemia. So the patient is a 37-year-old man who resides in Lagos, an engineer by profession and married. He okay, trying to change the slide.
Yeah.
Doesn't seem to be changing on my.
You can just unshare and then do it again. Stop the sharing and do it again.
All right. Okay.
Yeah.
Is it on slideshow now?
No, not yet. Yeah.
All right. Thank you. Okay. So the patient presented on account of easy fatigability, excessive urination, and weight loss of 3 weeks duration. He's actually a known diabetic diagnosed 3 years ago with poor drug adherence, and he presented with progressive generalized weakness, easy fatigability, polyuria, and weight loss. He had associated occasional hiccups, leg swelling, and the passage of frothy urine, but no associated nausea or vomiting. There was no fever, no headache, no cough or dysuria. He complained of paresthesias in the lower limbs and progressive worsening of his vision. There was no dizziness or syncope, no dyspnea, no chest pain, no differential limb weakness or intermittent claudication. He had a history of poor compliance with repeated hospitalization. So 3 months ago, he was admitted on account of poor glycemic control. And about a year ago, he also had similar symptoms requiring hospitalization. And 3 years ago, he was actually transfused. He was not a known hypertensive, and there was no history of stroke or transient ischemic attack in the past. He had a positive family history of diabetes in a second degree relative, and his mother had suffered a stroke in her 50s and had died within a year of this cardiovascular event. There was no history of sudden death in any other first degree relative under the age of 55. And he doesn't smoke cigarettes, drink alcohol, or take recreational drugs. So the medication prior to admission consisted of 2 grams of metformin daily and insulin glargine at night. Examination revealed a young man who was chronically ill looking. He was moderately dehydrated, and anthropometry revealed that he was underweight with a BMI of 15.82 kilograms per meter square. He had no cutaneous markers of hyperlipidemia. The cardiovascular system examination, the heart tachycardia, and the pulse rate blood pressure was low. The abdominal examination was essentially normal. Chest examination was also normal. The neurological examination was also essentially normal. Bedside investigations done showed that the blood glucose was more than 600 milligrams per DL. He had 2 pluses of glucose in his urine, trace protein, and the ketones were negative. D-dimer was also negative. So the problems identified in the patients were that of hyperosmolar hyperglycemic states in the patients with diabetes with microvascular complications and poor drug adherence. So the initial investigations carried out showed that the patient had some hypokalemia. Other electrolyte parameters were essentially normal. The fasting lipid profile results showed markedly deranged total cholesterol, LDL cholesterol, and triglycerides. He also had the A1C of 19.5%.
Dr. Williams, would you tell us how did you interpret this lipid levels that you saw here?
Okay, so the lipid levels were really high. They were markedly elevated, and the triglycerides were also very high. So these results were actually done. The L was measured using the indirect Friedwald calculation method. So it's possible that the LDL is unreliable. Usually, once the triglyceride is greater than 400 milligram per DL, the calculation method to assess LDL may not be accurate. And then again, the severe dehydration could have also accounted for the marked elevation in the lipid profile, because this was actually repeated about 2 days after the initial test, and it's actually showed some slight reduction in the lipid profile, although it was still very deranged. And this could also be as a result of the severe metabolic emergency that the patient was going through. These are the severe insulin deficiency as at the time of the hyperglycemic emergency, but it was still very alarming at the time of presentation, which necessitated the need to exclude other causes and consider the possibility of some primary hyperlipidemias.
Dr. Ken, your view? Yeah, we'll just take Dr. Ken's views on this and then we'll.
Yeah, this is a patient with very poorly controlled diabetes. Obviously, his glucoses are enormously high, and also his A1C, if I remember the number correctly, was 19%, which is tremendously high. It's important to recognize that a key enzyme in the metabolism of triglyceride-rich lipoproteins, lipoprotein lipase, is an insulin-dependent enzyme. It's produced predominantly in adipose tissue and in muscle. And insulin is a signal to increase the expression of that enzyme. And so a patient that's poorly controlled diabetes with very, very low insulin levels, with very little insulin action, will have very low lipoprotein lipase levels. And that will impair the metabolism of triglyceride-rich lipoproteins and lead to very, very high triglyceride levels. And I think that's what's going on in this patient. And as you treat his poorly controlled diabetes, you will see a marked improvement in his triglyceride levels. The LDL, I'm not going to spend much time on because it's a calculated LDL, and we just know the Friedwald equation doesn't work well once the triglycerides get elevated. And in this patient, the triglyceride levels are certainly markedly elevated. So I think we can ignore the LDL cholesterol levels now until we bring the triglyceride levels down. So your treatment that you're going to be using to treat his hyperglycemia and his hyperosmolar coma will have a beneficial effect on his triglycerides.
And also the A1C could also be falsely elevated because hypertriglyceridemia has also been found to cause false positive glycated hemoglobin levels.
Yeah. Well, we know his glucose is...
I mean, this is a chronically uncontrolled patient. So yeah, we know his A1C is probably over 13, 14, definitely, maybe 19, as you say, could have been influenced a little by the triglycerides, but the severe hyperglycemia and the history really, show this is a chronic condition.
The other investigations were essentially normal. Chest X-ray was normal, ECG was normal. We did a thyroid function test, which showed values within normal reference range. So the working diagnosis was a hyperosmolar hyperglycemic state in a known diabetic patient with microvascular complications and poor drug compliance, severe hyperlipidemia secondary to poorly controlled diabetes mellitus. And then we also considered the possibility of a familial combined hyperlipidemia. So the patient was rehydrated and treated with parenteral insulin according to standard management for hyperglycemic emergencies. He also had DVT prophylaxis. TABS atorvastatin was commenced, and fenofibrates were also added. So patients, there was significant improvement, and once the blood glucose panel began to decline, he was converted to basal bolus, and he was placed on a regimen of 10 international units of glargine lactate and short-acting insulin, 8 international units with meals. He also was counseled on diet and lifestyle modification to optimize his metabolic profile. He was reviewed by an ophthalmologist on account of the worsening vision, and they found bilateral immature tracts, which also alludes to the chronic poor control of his diabetes. So we continued improvement. The patient was optimized. Glycemic control was optimized on a dose of basal bolus regimen of glargine of 30 units lactate and soluble insulin of 12 units 30 minutes before food. And after a period of significant clinical improvement, he was discharged home. And we also made plans to trace first-degree relatives for screening. So we tried to reach out to the immediate older brother and his oldest son, who happens to be 10 years of age. So the take-home regimen was as above, including the fibrates and the statin. So 2 months post discharge, patient was re-evaluated. The glycemic profile had improved significantly. A1C was 11.4. The lipid profile was essentially within normal limits. The LDL was 50 milligram per dl, triglycerides 75 milligrams per dl. The patient had been on lipid lowering regimen for 2 months at this time. Further investigations that had been done to rule out other secondary causes were actually on the lipid profile, albumin, serum albumin were normal, and ABPI showed some mild arterial occlusion in the right lower limb. The urine albumin creatinine ratio was significant for macroalbuminuria. And then the lipid profile for the son was essentially normal. So based on the follow-up results, the atorvastatin was reduced to 20 milligrams a day, and the fenofibrates were discontinued, and patient was encouraged to continue lifestyle modification. Yeah. So to the approach to managing these patients, because these epidemias, generally, we want to reduce the risk of cardiovascular disease. And in many cases, there may be a secondary cause, as in this case. So we want to identify secondary causes because treatment of the secondary cause will go a long way to help in correcting LDL and lipid abnormalities. And then we also want to do a cardiovascular risk assessment to determine the modality of treatment and lipid targets. So there are various scoring systems that can be used to assess patients' cardiovascular risk, but generally there are certain conditions that are predetermined, and patients with those conditions are considered to be high risk or very high risk. For instance, patients with diabetes and patients with an established cardiovascular disease. So our patient was considered to be a high risk patient on account of his diabetes. So after risk assessment, the next thing is to do lifestyle modification and then apply pharmacotherapy to achieve glycemic. So like I said before, secondary causes of dyslipidemia are important to be excluded because treatments would also be targeted to correcting these abnormalities and controlling these risk factors. So according to the guidelines, patients who are considered to be very high risk are patients who have a documented atherosclerotic cardiovascular events, either clinically or documented by imaging, and then patients who have diabetes with target organ damage, or patients with severe chronic kidney disease. So the patient that was presented fell under the category of high risk because he was a patient who is diabetic, but he had other associated factors such as the markedly elevated LDL and the presence of macroalbuminuria, which actually increased his risk to high risk. So in patients that are asymptomatic, apparently normal, other scoring risk assessments can be used to determine their risk. And this is an example of one of such risk evaluation charts. So this one is the systemic coronary risk estimation evaluation, which is called the SCORE risk chart, and is used to determine whether a patient is low risk, moderate risk, high risk, or very high risk, using the parameters like the age of the patient, the gender of the patient, the present, a history of smoking or non-smoking, and the LDL baseline LDL values. And then we also have what we call risk modifiers that can also be used to adjust the risk of the patient based on their presence. For example, a patient may have a moderate risk, and then he has other conditions like he has a chronic immune inflammatory disorder, or he has chronic kidney disease, or he has some other metabolic problems, maybe C-reactive protein levels are elevated, or there's a family history of premature coronary artery disease. So such risk modifiers can be applied to the risk assessment scale to either increase or to escalate or de-escalate the patient's position on the risk chart. Then after the patient is assessed and the risk category is determined, then the targets for LDL lowering can be identified. So there are usually two groups of patients to be managed in the setting of hyperlipidemia, and that is the patients that are getting secondary prevention and those that are getting primary prevention. So secondary prevention is indicated in patients that have a documented atherosclerotic cardiovascular event, and the therapeutic goal is to achieve LDL lowering of more than 50% or a target of less than 55 milligrams per dl. So primary prevention would involve patients who have not had an atherosclerotic cardiovascular event, but they are high risk or very high risk of developing an atherosclerotic cardiovascular event. And according to the guidelines, the very high risk patients will have the same therapeutic targets as those on secondary prevention, with an LDL goal of less than 1.4 millimole per liter. So for our patients who fell under the category of high risk, therapeutic goal for him is an LDL less than 70 milligrams per dl, which would usually be achieved using a high intensity statin. So at the time when we had to discontinue or to reduce the dose of the statin, patients were already having an LDL level that was about 50 milligrams per dl. So for patients with moderate risk, a goal of less than 100 milligrams per dl will be adequate. And for low risk, less than 116 would also be appropriate. And these patients could then be controlled by lifestyle modalities with or without medication. Thank you.
Thank you, Dr. Williams. Your case has actually brought out many important points that need to be highlighted. One is the fact that whenever you have a very severe hyperglycemia, the interpretation of lipid levels should be made with caution. And whenever you're dealing with severe hypertriglyceridemia, then you need to look at the way the LDL is calculated. Is it calculated LDL, or is it the direct measured LDL? And then you make your interpretations based on that, and always wait for correcting the hyperglycemia before you embark on deciding about how important the lipid levels are. And also the other important point that you've highlighted is that with the correction of hyperglycemia, you've shown the remarkable improvement in the triglyceride levels that were achieved in your patient. So I think that's an important message that was brought out by this patient, by this case. And you also discussed about the lipid stratification of the risk and the targets that need to be achieved. So I would like to ask Dr. Rupa that even after correcting all these things and looking after the secondary causes of hypertriglyceridemia, we still have a significant proportion of individuals who have a hypertriglyceridemia. So how do you propose to manage these patients, and how do you look at managing the triglycerides?
So we in Mexico, I think just like in India, most of our diabetic patients have an atherogenic profile. So they have hypertriglyceridemia, low HDL, and small dense LDL levels. So this is a very typical dyslipidemia associated with diabetes, with metabolic syndrome, even with obesity. So here I find that the LDL target sometimes is not enough. So I would bring my patient to an LDL target, but I would also calculate non-HDL as well and try and get my patient to the non-HDL target. Now, the guidelines do recommend this. They even recommend measuring ApoB if we can, because ApoB gives you an idea of the total number of atherogenic particles. And this is really to tackle the residual risk that most patients face, even though we get them to the LDL target. And obviously the guidelines are still very much statin-based because the evidence is there. The evidence for fibrates is not so strong. In fact, most of the trials have only found benefit in the subgroup of patients, but this has always been subgroup analysis. This has not been a trial dedicated to patients who have this atherogenic profile. So a trial is being carried out right now. It's called Prominent, where they're looking at pemafibrate and looking specifically in diabetic patients with this kind of, that way we will know the benefit of possibly a fibrate. But right now the guidelines recommend statins, ezetimibe, and even if you have these EPAs, which we don't have in Mexico, is another option to add. I just wanted to add, talking about the LDL calculation, in our laboratory, we've added in Martin's formula as well for the LDL estimation in the lab results, because we have so many patients with metabolic syndrome that the LDL calculation is often not very accurate. So with the Martin's formula, especially in cases with hypertriglyceridemia, we're getting a better estimation of LDL, and that will help us get people to target. So that's one change we did in our hospital, and I think it's had an impact.
Could you tell us something more about that? I mean, because our viewers would like to know more.
Well, because Friedwald uses a fixed ratio to estimate the LDL. So it's triglycerides divided by 5, which in the case of hypertriglyceridemia is probably not true. Martin's formula, there's an article written now a few years ago, I think 2013, maybe Dr. Ken knows about it, but it's actually takes into account. So then this division by 5 changes to the normogram. So you put in your triglycerides you, and then it gives you an estimation of it. We published an article on this, and we found that the correlation was much better using Martin's formula in this subgroup of patients. Dr. Ken, there's also been a Samson's formula that's also been published, but we've stuck with Martin's for now. Dr. Ken, what do you guys?
Many people are using the Martin-Hopkins formula. In fact, if you go online and you just plug in Martin-Hopkins LDL cholesterol, it will give you the formulas, and they actually have ways that you can have set it up on your computers to allow you to do this in large numbers of patients. And it's much more accurate, particularly in patients that have either high triglycerides or low LDL levels. And that becomes important now because the way we're treating people, we're getting some really low LDL levels. And the Friedenwald equation doesn't work well when the LDL cholesterol levels are very low. So I think everyone should switch to this. In fact, in the United States, Quest, which is one of the big laboratory companies, is now using the Martin-Hopkins when they report their LDLs. And I think over time, more and more people are going to stop using the Friedenwald and switch to these other formulas. And the NIH has one, and there's just better ways to do it. So I think that's going to occur. My approach to the lipids in patients with diabetes has changed over the last year or two. Basically, I first focus on the LDL cholesterol. And my aim is to get that LDL cholesterol into the goal. And depending upon the particular patient, the goal will be different. So I'll use statins, of course, and I'll add ezetimibe, in some cases, add a PCSK inhibitor. Now, I then look at the triglyceride levels. And the reason I look at the triglyceride levels, and I don't even bother calculating the non-HDL cholesterol, is that if the patient is a diabetic and has cardiovascular disease, or the patient is a diabetic with risk factors, I am now using a purified preparation of EPA, because the REDUCE-IT trial, shockingly, was showed such benefit. It showed over a 20% reduction in events in this patient population with adding this drug. And I don't think it worked by lowering the triglyceride levels. I mean, in fact, the data suggests that the triglyceride level effect could not explain the beneficial effect. But nevertheless, this patient population, by however this EPA works, whether it's stabilizing membranes, acting as an antioxidant, reducing inflammation, affecting platelets, the list goes on of the potential mechanisms by which this drug works. It was so profound to me that it seems like many of my diabetics with the metabolic syndrome and these high triglycerides, that they should be on this drug, because obviously they have multiple risk factors. I mean, they have hypertension almost always. They have low HDL cholesterol levels. I mean, they have just a lot of other risk factors. And so that's what's happening to me, is that I'm going LDL and then using the brand name in the United States is Pacepa. I don't know what the brand name is in other countries, but I've been adding that more and more to the patients to reduce their risk by over 20%.
What's the dose that you use?
It's 2 grams in the morning, 2 grams in the afternoon, in the evening. So it's 4 grams per day. The one problem with the drug is it's expensive, like everything else in life, like the PCSK9s. I mean, everything comes with a high cost. I have no idea what it would cost in India or in Mexico, but I know in the United States, it's a fairly expensive drug.
It is.
We don't have it.
It's not very expensive, but it's more than the statins.
Yeah.
Yeah, the statins in the United States are generic and basically almost free. I like to tell people it costs them less to get a month's supply of a statin than the toll to cross the Golden Gate Bridge. The toll on the Golden Gate Bridge is more expensive than a month's supply of the statin. That's the way I justify it to patients. You know, if they can afford to go over the bridge once a month, they can afford a statin.
Yeah.
So when you're dealing with hypertriglyceridemia, are you looking at a target level, or you're?
I'm just starting them on the Vacepa and not worrying about what the triglycerides do. The triglycerides go down. They'll go down about 15, 20, 25%. but that may have nothing to do with the benefits. As far as the fibrates, I'm sort of on the fence, and I'm waiting for the big prominence study to see if it really works. So far, what we have is, as Dr. Mehta said, is we have these subgroup analyses, and those are always have the potential for problems. Statisticians do not like subgroup analyses if the main group didn't work. So, I'm on a fence there, and I've gone to using more Vascepa than to using fenofibrate.
Whereas in Mexico, because we don't have the EPA, I do have patients who are on statins, ezetimibe, and then if they have significant hypertriglyceridemia despite dietary management, I do consider adding in a fibrate. But again, I'm running the risk there of the side effects of combining the statin with the fibrate. So sometimes I leave them with 3 or 4 days a week with fenofibrate because I know that will help their retinopathy. And so that's the main reason I add it in. Fenofibrate benefit in diabetic patients.
I'll make one other comment. EPA, of course, is an omega-3 fatty acid of fish oil, but you cannot substitute the over-the-counter fish oil products or even other fish oil products, because there's now a study that has not yet been published, but which there's been a press release on called Strength, where they used a combination of EPA and DHA. And unfortunately, that study did not lead to a reduction in cardiovascular events. It was stopped for futility. And so it appears that the combination of omega-3 fatty acids of EPA, DHA, which can be bought much more cheaply, doesn't seem to have the benefits on cardiovascular disease that purified EPA alone has on cardiovascular disease.
And I'd just like to add as well that there's obviously part of the residual risk are these remnant particles that we may see in states of hypertriglyceridemia. So the aim, it may not be that fibrates are the answer. I think the answer is just reducing all your atherogenic lipoproteins. So whatever drug or method we find to reduce that will probably have an impact on cardiovascular risk. So it's not just the LDL, it will also be these remnant particles with which we actually estimate remnant cholesterol. We can find a way of reducing that as well in these patients, that will have an impact. And of course, the best estimation will be ApoB, I imagine.
For people who don't have access to ApoB, or because of the expense of getting ApoB, the non-HDL cholesterol, as Dr. Mehta mentioned earlier, can be a reasonable substitute if you're in a situation where that's not going to be easy to get an ApoB level. And that may be true in many parts of the world. And I even know in the United States, it adds a considerable extra cost for certain patients. So you can use the non-HDL cholesterol as a reasonable approximation. And the non-HDL cholesterol, of course, is free, because if you know the LDL and the total cholesterol and the HDL cholesterol, you can calculate the non-HDL cholesterol sort of free of charge.
And there are formulas to estimate remnant cholesterol as well. But again, they use LDL. So if the LDL estimation is not accurate, that will also influence your remnant cholesterol calculation. But as Dr. Ken says, it's really the non-HDL that I use in the clinic in these patients.
So I think we had a wonderful discussion. I would like to ask Dr. Ken to give his comments to summarize today's discussion and say what his final take home is for everybody.
Well, I think we've covered a lot of different situations, but I think the take home is people need to pay more attention to lipids, with the idea not so much of treating the lipids, but rather to prevent disease and to prevent cardiovascular disease, because it's clear that one of the major risk factors is abnormalities in lipids. And in fact, I've heard people say, and actually it was some famous people say, that if we all had LDL cholesterols of 50, cardiologists would be out of business because we wouldn't get very much cardiovascular disease. It would have a remarkable reduction. So I think we really need to be thinking about prevention of cardiovascular disease, and that's the reason to treat lipids. And it would be analogous to treating blood pressure. And we need to be very aggressive doing that. And I have like two mottos that I like to give to medical students. The first is lower is better. And there's a lot of evidence that the lower the levels are, the fewer events you get. And the sooner you begin, the better. So if you can begin at an early age, not begin after they have an event, you can have a much more effect on outcomes. And that brings one to the need for screening and following patients closely. Beginning early is important. And I actually, in the United States, we use this pooled equation. I actually pay attention to the 10-year risk, but I actually, in younger people, pay more attention to the lifetime risk, because the lifetime risks are very, I mean, you'll take a 45-year-old and you'll see that their 10-year risk is only 2% or 1%, incredibly low, where you would say, no worries at all. But then you look at their lifetime risk and it turns out to be 45%. And when I tell a patient they have almost a 1 in 2 chance of having a cardiovascular event sometime in their lifetime, that's pretty motivating. And so spending time on the lifetime risk, I think, is very, very important, because that will determine, at least in my view, whether we should go ahead and treat or not treat. The 10-year risk is fine if you're 65, 70, but if you're relatively young, the 10-year risk doesn't mean that much. And it's just a final, I should say, the endotext has a huge section on lipids, which I'm actually one of the section editors on. And I think it covers many aspects that we've talked about here in much greater detail. And you can use that as a reference textbook because, as many of you know, it's free. We don't charge for the use of endotext. All one has to do is register, which takes about 2 to 3 minutes. And then you have access to all this information on endocrinology totally free. And so I would highly recommend for anyone who wants more information to go ahead and do this, and they can scan various chapters and look up various things and use it as a reference source.
Thank you, Dr. Ken, for the wonderful insights that you've given today. I would request Dr. Rupa Mehta to tell us, give us some insights about what she has felt about the two cases and what is the take-home message she wants to give to all of us.
So I think the two cases highlight that when we come across a lipid profile, and it has to be a complete lipid profile, you can't just base a diagnosis on a cholesterol level or a triglyceride level, an isolated level. So you need the complete profile. Then you have to decide on the phenotype of the dyslipidemia that you have, and that will help you start thinking of possible differential diagnoses. And again, secondary causes of dyslipidemia will obviously be much more common than possibly the primary causes. So treating, for example, hypothyroidism, we will improve the lipid profile. And then we come to cardiovascular risk estimation to kind of then decide what will be our targets in each individual patient. So I think we need to go through this kind of checklist every time we see a lipid profile. And sometimes we don't. I have a feeling that sometimes lipid profiles, it's almost a knee-jerk reaction. He's got high cholesterol, let's start a statin. But no one looks into why this patient may have high cholesterol. What could be the factors influencing this? Can we normalize this without a statin? So all this has to be part of the workup. And I think both cases were excellent for discussion. I think we discussed so many aspects, I can't even go into those, but more than anything, I think it's just remembering that. Go through that checklist when you see a lipid profile, and then consider these primary dyslipidemias that are quite rare, and you need to work through those, with family history, with doing a family tree, and then like cascade screening like we saw with familial hypercholesterolemia. So, and then with the second case, I think it just showed us how metabolic derangements, especially glucose, can influence the lipid profile. So it's really correcting the hypoglycemia with insulin is going to really improve that lipid profile. So I think I'll leave it there. I agree with Dr. Ken. I've used Endotex. It's really great. It's free. Use these resources. When I was younger, I didn't have these things. So, you know, you guys use them and learn. And thank you very much for inviting me. This has been a great discussion.
So thank you, Dr. Rupa Mehta, for the wonderful insights once again. You have given us very useful information on how to go about with evaluating dyslipidemias and how to go about managing them. And I would like to also thank our two presenters, Dr. Aishwarya and Dr. Williams, who have done a wonderful job. They have brought in very interesting cases which brought in a lot of discussion, and I think we have really benefited from the discussion. And once again, I would like to thank each one of you for attending this program, all the attendees who are here today. I'm sure there are a huge number of attendees who are there, and I see a lot of comments on the chat box appreciating the discussion. So I thank all of you for coming here and spending your time. And then I would like to also highlight also inform you all that this is a monthly series that we're going to have. This is the first one which we had, and the next month is going to be on pituitary disorders, and then we're going to have the next one on adrenal disorders. So keep watching out for these webinars, which are going to be regularly held in collaboration with Endotext. And as was mentioned by Dr. Ken and Dr. Rupa, Endotext is a very useful resource which I think all of us should use, and we will all benefit from that. Thank you all, and I thank everyone, each one of you, all the faculty for being here, and I thank Torrent Pharma also for sponsoring this event. Thank you.